initiate your improvement. Physiotherapy will going to help him to make his muscles live. If he will do physiotherapy, muscles will be live, otherwise atrophy, they will go in atrophy. Because if we will do the brachial plexus surgery, brachial plexus, we have grafted and we have just did the anastomosis. Then the improvement of the nerve regeneration will start 1.5 to 1 centimeter a year. Then till the sensation will come to this level, then till that time the muscles will be atrophied. Then you will not be in a situation to improve. Physiotherapy will going to help you to make your muscles live till the nerve stimulation will be reached to your muscles. To keep them live, you should do exercises and physiotherapy. Physiotherapy will going to help him in that way.
Thank you so much, sir. So there is a correct guidance that we require to teach the patient, like what to do, what to not to do, and how we can add on the movement, and how we can add on the life to the muscles, how we can maintain the muscle strength. That is the main key of the neuro rehabilitation. Thank you so much, sir, for sparing time for us and for giving the guidance and blessing always. Thank you so much, sir.
Thank you so much, sir. I would like to request Dr. N.C. Poonia, sir, to please felicitate our panel of physiotherapists, Dr. Anchit Gugnani, sir, Dr. Darshika Vyas, ma'am, and Dr. Ashutosh Sharma, sir. Please, sir. Please give a big round of applause for sir. Thank you, sir. Thank you so much.
I'm honored to introduce our distinguished guest for the third symposium in the sports condition, Dr. Arun Partani, sir. He is a joint replacement surgeon, sport medicine specialist, additional director in orthopedics and joint replacement at Fortis Hospital. Now, I would like to request Dr. Mayur Singh, sir, from Million Lines to kindly come on the stage and felicitate with token of gratitude. Give a big round of applause for sir. I request Dr. Arun Partani, sir, to please take your seats. I would like to introduce our panel of physiotherapists for this sports symposium, Dr. Vishal Jain, sir. He is a dean and professor at Department of Physiotherapy, JECRC University, Jaipur Engineering College and Research Center. And Dr. Akshat Mathur, sir. He is a director and chief physiotherapist at Smash Clinic. Give a big round of applause, sir. Now, it's time for our presenter, Dr. Tripti Jain. She is the resident of Master of Physiotherapy of Jaipur National University.
Good evening, sir. Today the topic is ACL injuries, examination, and the management. I would like to. Yeah, please.
So I'm really glad that this JPN has completed 10 years, and Mayuri called me and sir आपको ज़रूर आना है. मैंने कहा JPN is not an event where I am an invitee. It is an event where rather I'm a host. I have grown with JPN, and I still remember the very first meet which we guys did, and I've been associated with it since the inception. And not as a guest, but as a friend. Most of you guys, they know me. We sit together. We have enjoyed together. We talked together, and I really am proud to see the grandeur of the event, the scale of the event, the participation, and Katkar sir, as he rightly said, that we grow together. We support each other, then we grow together. That the crux of all these kind of events, to build up a relation among ourselves, support each other, and let the branch become bigger than this, what we see it today. And in the last 10 years, I've seen even the physiotherapy awareness, among the patient, and affordability for physiotherapy. Everything has increased. The scale of physiotherapy centers and machines have increased like anything. So all in all, I would like to heartily congratulate all you guys for such a nice event which you are organizing.
Thank you so much, sir. Thank you, sir. Thank you so much.
Now we can start the topic.
You can start the topic.
No, so we are talking about ACL.
ACL injury.
So ACL, if we talk about ACL, there are a lot of things which we keep seeing, and me and Akshat have again spent together quite a good long time for these things. So ACL, when we say ACL injuries, there are three kind of injuries. One is a partial ACL tear, second is a full thickness ACL tear, and third is ACL avulsion injuries. So again, as Dr. Abhishek and Dr. Lalit rightly discussed, we are here not to treat a MRI, we are here to treat a patient. So what is important is what the patient comes to us with. And ACL, one is the primary stabilizer against the rotation instability with a lot of proprioception input to the knee. So we as a surgeon and you as a physiotherapist, we have to first examine how much is the instability, what are the demands of life, what's the age of the patient, what's the condition of the knee, and then we have to come up with a plan to treat him. So not every patient will require surgery, not every patient can be treated with physiotherapy alone. So it has to be a combination which we formulate as per all these four things. So in the start, number one thing which always we emphasize is that post-injury, don't let the knees become stiff. We cannot operate a hot knee. So once the ACL is injured, give physiotherapy, give icing, give supportive treatment, and let the knee be free and fully mobile before we plan to touch it surgically. So physiotherapy role is important pre-surgery to achieve the full range before it can be good enough for the surgery, number one. Number two, ACL avulsion is a different thing. It should be treated as early as possible because we were fixing something. We are not replacing it, we are fixing. The fixation should be early. And partial tears, again, you have to customize your treatment plan as per the requirements, because I have had my patient who are national level kabaddi players but having a full thickness ACL tear in the MRI, but the knee is stable because of the muscular inputs, we have to see the knee in totality. So we cannot do a segmental division of the knee, this and that. Ultimately, sometimes we see the knee become stable because the agonist for the ACL are working really well. So you start your treatment plan as per these four things. And again, after surgery, it's very important to do a very good physiotherapy. No surgery can be successful without a good physiotherapy. And we condemn the people who say that I do a surgery and I don't need physiotherapy. That's bullshit. No orthopedic surgery is complete, or no orthopedic surgery can give a good outcome without a well-planned, dedicated, good physiotherapy, especially with ACL. I would say we make sure that it is, as Dr. Lalit said, it is not just the movement which we strive for, it is the function which we look at. And the function comes with range, strengthening, proprioception, balancing, agility training. So the ACL rehab is a big thing and it spans over at least 10 to 11 months. It is not 4 days, 6 days, 6 weeks or 2 months. The rehab should go all the way up to 10 to 11 months before the patient can come down back on the mat or back on the sports.
Sir, I want you to talk about the importance of early investigation and how a physiotherapist look into a knee while he is receiving a patient in the OPD, and the person is just having an injury and he is coming into a OPD and you are a physiotherapist. So as a physiotherapist, what a physiotherapist should see,
do.
and
So-
he should mobilize the knee joint and check the laxity, or what he should go for the investigation first.
So first of all, you should see whether there's a medial lateral mobilization. So first of all, ACL many times is associated with the MCL injuries. So if the knee is lax mediolaterally, how much is the opening? It is at grade 1, grade 2, grade 3.
Sir, the investigation, but I know I've learned from you only, but the importance
We
of...
learned together.
Yeah, but the importance of early X-ray to just rule out the emergence
Yeah, so that's what I was coming to.
Yeah.
So first of all, ACL ke saath mein always check MCL. Number 2, get an X-ray always. Early MRI is not a mandate, but early X-ray is, because as I started, ACL avulsion is a different entity altogether, because there you would require an early surgery. So get a normal X-ray. Try to read it well, because as a physiotherapist, you should be able to read into the basic investigation by yourself. We should not be dependent on the reports which a radiologist writes, because again, we should see it in the clinical perspective. So you should first of all be able to delineate whether there is an avulsion fracture or not. If there is no avulsion fracture, then we can start with a regular physiotherapy, which means your mobilization, icing, compression, strengthening, and if there is a mediolateral laxity, a brace support. But I don't support making the patient in a plaster, putting a plaster on the patient with an ACL injury, because that makes the knee stiff. So you mobilize early if there is no bony injury, no avulsion, and no MCL involvement. Number 2, MRI. Second investigation which we generally look at is an MRI, but don't rush for an early MRI. MRI, they over-report things in the early injury, because immediate post-injury, the tissues are swollen, they have a lot of edema, and edematous tissue on an early MRI can give a false sense of a total tear. So you should wait for at least 10 to 15 days post-injury to see, order, or evaluate an MRI.